Buenos días a todos e gracias per l'invitazione. I will need to speak in English, so I would like to thank Oncoliado for the invitation and of course my friend Dr. Soteldo, who invited me several times to Venezuela. Per procedere, I don't have any disclosures for this presentation. I will talk about melanoma and skin cancer, of course. And to talk of this topic, I would like first of all to start with a little bit of history about melanoma. And the history of melanoma is strictly linked to two persons that were my teachers. Professor Veronesi, that all the people of my age knows very well, also in the places outside Italy, and of course in Venezuela. I'm sure that everybody reminds Professor Veronesi, and Professor Cascinelli, who's been my direct teacher on melanoma. Why did I mention these two persons? Because we are talking of the middle of last century. They have really changed the concept of what melanoma is in the world. And believe me, not inventing a new treatment, but just educating doctors, they succeeded to change the concept of an incurable disease to a disease that can be easily cured in the majority of cases. So the prognosis of melanoma in the middle part of last century has changed using educational programs. And I will show you what they did. Because now for us, it's very easy to say that this little lesion is a primary melanoma. This one, as you can see here. But originally, in the middle of the last century, this lesion would have not been excised and would just been left there. The big problem of that period was that primary melanomas were not recognized when they were little, but they were recognized only when they become large and bleeding. But also that when they were going to excise some primary lesions, they were not sent to the pathologist. They did not do any histology. And this is a major problem because if you don't examine the lesions that you excise, then if the patient goes to the progression of the disease, you don't know what happens to this patient because you don't have the original diagnosis. So this is absolutely very important. The only lesions that were excised were the lesions that became symptomatic. So it means that they had only to be bleeding, they had to be thick, 1.5 centimeters, they were very large. So those that were called benign were instead primary melanomas, and when they excised these lesions, sometimes the disease was progressing, and originally the concept was that you excised this mole, and the reason that the patient had a melanoma is because you excised this mole. It's the old concept in Italy, we say, don't touch the dog when he's sleeping. I think in every place we have this concept. In Italy, it was very difficult to change this mentality, and now, finally, we succeeded to do this. But the concept is exactly this. If you touch the mole, then the disease would explode. It's completely wrong, of course, but 50, 70 years ago, this concept was not easy to be modified. The project of Cascinelli and Veronesi in the World Health Organization lasted 4 years. And in 4 years, they really changed the prognosis of melanoma, putting together experts from different parts of the world. And the results were very good. The results were very good because they started to excise and to send to the pathologist lesions which were very little, not just very large lesions. And this really been the most important issue. So Italy has all the countries, the Western countries, the melanoma problem because, of course, of the incidence, which is very high. In Italy, we have these kind of numbers every year, more or less, and the point is, who are now the patients who really have a big risk for melanoma? The 80% of our patients are cured by surgery mainly, but there is a percentage of 20% of patients who develop stage 4 disease. Of these, before the new treatments, the new medical treatments with anti-CTLA-4 and anti-PD-1 mainly, but also with target therapy, of the 20% of patients, only 5% of those patients were cured by chemotherapy. Now we are close to cure 50% of our patients with the new therapies. And this means that we save much more than only 100, 150 patients of the 2,000, 3,000 patients who have progression of the disease after surgery. And now we succeed to cure at least half of those, which is a very important aspect. The surgical treatments are mainly dedicated to stages 2 and stages 3, of course. But talking of stage 1 and stage 2, the big issue has been for several decades the concept of the margin of the resection. I would say that using the studies that has been conducted so far, and there are several studies, the great majority of the studies have indicated that 1 centimeter margin is more than enough. Even if still now we have a study which is the MELMART 2, which is comparing 1 versus 2 centimeters. The results will be ready in the next years, but I'm pretty sure that the result will say that 1 centimeter margin is more than sufficient to excise in the correct way the primary melanomas. If you want, you can get in touch with one of these who are conducting the study. So what about this situation? Why should we do a very large excision in front of this primary melanoma? 1 centimeter, trust me, is more than sufficient to do a radical excision of this primary melanoma. On the same way, why should we do a 5 centimeter margin around this primary melanoma? This is a very bad lesion. This lesion is not more a stage 2. This patient is already a stage 3 because he has these 2 little things here which are clinical evidence of progression of the disease. These are so-called satellitosis or in-transit metastasis. And this means that this primary lesion is no more just a primary lesion, but the patient has already a progression of the disease on the skin around. So there is no benefit of doing a very large excision for this lesion because he will recur somewhere around the scar that you are doing, whatever is the margin that you give him. Or this one, to dermatologists, do not burn primary lesions even if you think they are benign. This was certainly a little primary lesion here, which probably was not pigmented or whatever. He thought it was a wart, or I don't know what he thought, but he burnt it with no histology, and this, after a few months, is the result on the back of this patient. So always do a histological evaluation of what you want to treat. Do not burn without histology anything. And finally, the role of the pathologists. The role of the pathologist is absolutely fundamental. It's very important because we can use the classical staging to stage primary melanoma, which means in the different levels of thickness, and the thickness is the most important parameter for primary melanomas. But anyway, the role of pathologists is very important because we want something more than just to measure the physical dimension of the primary melanoma. We want something more related to the biological aspects of the primary melanomas, and mitotic rate is one of these. It's the most simple. Then we shall see the role of the gene profiling. But of course, to start at least with the mitotic rate, which at the moment is no more in the classification of primary melanomas, it's very important. And the mitotic rate is something that pathologists need to calculate in the same way, because if you don't have the parameter measured in the same way, then of course it cannot be compared. It will be like comparing apples with pears. It's not possible. You need to convince the pathologist to use a unique method of evaluation of the mitotic rate. Let's go to the progression of the disease. Let's go to the concept of the nodal management of our melanoma patients. There are two main aspects. One aspect is to do the sentinel node biopsy, and the other aspect is the role of the lymphadenectomy. That is very important. Now, the sentinel node biopsy concept, I think everybody knows everything about, and it's the identification of the first filter of the lymphatic stream, the first node that receives the lymph from the area of the skin where the primary melanoma was. In this way, we try to identify the place where it's more probable that we have tumoral cells into the nodes of our patients. We do the sentinel biopsy when we have a primary melanoma thicker than 8 millimeters, or in the cases of a thin melanoma, if there is a very large regression, more than 75% we say, or in case of ulceration. It's very clear that the prognosis of our patients is related to the presence or absence of metastasis into the sentinel node. So if there are no metastases, the prognosis is much better, of course. But we are not able to demonstrate that to do or not to do the sentinel biopsy is really able to change the prognosis of our patients, because we made several studies on sentinel node biopsy, doing it or not to do it in the randomized fashion, and we never succeeded to demonstrate that to do the sentinel biopsy or to keep the patient under observation, it would change the prognosis of the patients. But we still do the sentinel biopsy because it's a very important prognostic information that we have of our patients. In the future, what we expect? Well, we expect the concept that the gene expression profiling will help us a lot in identifying the patients who really need to do the sentinel biopsy. The example, one of the examples is the Merlin test, which will examine, for example, 8 genes, and from these genes we shall be able to select the patients who will really require to do the sentinel biopsy from those who do not need to do it. So we just need to excise the primary melanoma and that's it. If the gene profiling is in the setting, showing us the setting of a very good prognosis, why should we do the sentinel biopsy? Is the probability of having metastasis is virtually zero. So we will be able to select patients who require a more important approach, which is to do, for example, the sentinel biopsy, from those who don't need to do it. In stage 3, we have 3 different scenarios. We have the patients with the so-called satellites or in-transit metastasis, or macrosatellites, which are not clinically evident, but the pathologist finds in the skin around the primary melanoma some tumoral deposits. We have the patients with macroscopic deposits into the sentinel biopsy, and we have the patients with a palpable node. We still have some of these patients who come to our clinic or who do an ultrasound, who do a CT scan, and we find the presence of locoregional disease into the nodes. So there are different situations from the clinical point of view. Let's have a look to a patient that I treated with satellites. The situation of the satellites is that whatever we call them microsatellites, satellites, or in transient metastasis, the prognosis of these patients is absolutely very similar. And they are classified in the same staging group. This is the patient I saw a few months ago in Milano, and I think that this patient teaches us a few things. First of all, the treatment of the primary melanoma. I think it's something like 20 years that I don't do anymore an amputation of fingers of the hand, of toes of the feet. It's absolutely unuseful to take away the fingers of somebody because the primary melanoma, in this case, was in between the two fingers, the two toes of the foot. It's just not invading any bone. So if you are not able to do the plastic surgery repair, call your plastic surgeon. He will help you to do whatever he needs to be done, because we just need to take away the skin with an adequate margin around the primary melanoma, and that's it. You wait 1 month, you wait for the granulating tissue to grow, and then you just put a skin graft on it. Why do you amputate patients in this way? It's absolutely unuseful. And this is the first message. The second message of this patient was that she started adjuvant treatment with target therapy. Just after a few weeks from the surgery of the primary, she was telling to her medical oncologist, and we are talking of a medical oncologist in the north of Italy, very, very close to Milano, in a big hospital close to Milano. So not the peripheric place, you know, in the south or wherever, in the mountains of the north where there is no culture, but it was in a very, very well recognized hospital in the north of Italy. Well, this patient started to say to the doctor, I got some little lumps growing in my leg. The doctor, for a few months, did not even watch on the leg of this lady. Then she said, Doctor, I have more than 2, 3 like before. Now they are becoming 6, 7 lesions, all very similar on my leg. And finally, the doctor started to watch the lesion without recognizing it. Well, it took 1 year before the doctor decided to send to the dermatologist or surgeon of her hospital this patient to do a very simple biopsy of one of these, and of course it was an in-transient metastasis. So, first of all, the second message is, if you don't know the natural history of the disease, you must learn what is melanoma, what is the melanoma behavior before starting to look after these patients. It's absolutely strategic that, first of all, the patient is listened by his doctor, because if the doctor doesn't listen to the patient, then it's a disaster, of course. And second, that if you see something like this, even if it's not pigmented, because you see, these are not pigmented lesions, I just made a little circle with a pen around the lesion, but it's very important that you think that this can be a progression of the disease. So after a year, the patient, instead of changing the therapy, few months after the start of target therapy, she was turned into immunotherapy. And now, hopefully, she's doing well. So, in case of in-transient metastasis, what we do now? First of all, I would try to include the patient into a clinical trial, if you have a clinical trial available. Second alternative is to start immunotherapy with, first of all, anti-PD-1. And then, of course, you can, if anti-PD-1 fails, you can offer target therapy. But then we also have something else in case of in-transient metastasis. If it's feasible, you can operate on this patient. If it's not feasible, then you can do what we call the integrated surgical procedures. One of these is the limb perfusion, which isolates from the body circulation the limb, and you do a hyperthermic chemotherapy infusion in your leg. Or you can use the electrochemotherapy I think everybody knows about electrochemotherapy. It's the combination of an electric pulse and the infusion of chemotherapy of bleomycin, and this obtains a very, very good, but just local, of course, result on our patients. So the other step, the other situation we have in stage 3 is the presence of positive sentinel nodes. What are the sentinel nodes? We saw it. The situation of the staging of stage 3 is now divided into 4 groups. Originally, we were doing a complete lymph node dissection every time we found a positive sentinel node. Then we did 2 studies, one in Germany, and the other one was the MSLT2, which was a global study around the world. And we compared, of course, observation versus a lymphanodal dissection. The results were absolutely similar, so nowadays we don't do anymore a lymphanodal dissection when we have a positive sentinel node. And we do adjuvant therapy. The last situation is the situation of a patient with macroscopic disease, which means that you can find it by palpation or you can find it because of ultrasound or instrumental evaluations with CT, for example. And you have already the diagnosis of stage 3 without doing the sentinel biopsy. What can we obtain? And this is still the standard of treatment in Italy, for example. What can we obtain with a lymphanodal dissection? Well, you obtain certainly a locoregional control of the disease. You obtain a very good staging because you will be able to know how many nodal metastases are present in the nodal basin of this patient, but you probably don't offer a better survival than doing other aspects of treatments. So far, the indication in Italy, for example, is to do a complete lymphanodal dissection and then to go to the adjuvant treatment. The alternative could be to do just the excision of the single node and to do the adjuvant treatment. Then if the patient recurs, you again take away another node and you do adjuvant treatment. But I must say that the preliminary results of the studies that I will show you are going towards the concept of the neoadjuvant treatment. Neoadjuvant treatment means with immunotherapy that you first treat the patient with immunotherapy, and this is certainly the best situation that you can offer to your patient because the immunotherapy will be enhanced by the presence of the tumor and will recognize all the tumoral antigens that will create the reaction of your immune system against the tumor itself. And this is certainly something that we shall hear about much more in the next years. The concept of doing this goes through the concept of the index node because you identify the specific node which is involved with disease and you put a radioactive marker and then, of course, you do the medical treatment. The preliminary studies that I was talking about to you are the SWOG1 and the NADINA study. These 2 studies show the difference in between doing for stage 3 patients, so the patient with nodal metastasis, either the immunotherapy in the neoadjuvant setting or the second curve, the adjuvant therapy after the lymphanodal dissection. You can see how the 2 curves are different, how the blue curves are much better because you treated the patient with the cancer present in their body. And it was a lymphanodal metastasis for melanoma. You see how different they are, the 2 curves. This is the basis for the MSLT3 study, which is just starting to enroll patients. So also Venezuela can take part to this study, of course. And the concept of this study is to compare the patient who will get the neoadjuvant treatment plus the lymphadenectomy to the patient who will get the neoadjuvant treatment and observation mainly. So at the end of this, we shall be able to say if the neoadjuvant treatment is really efficacious or it's better to do a lymph node dissection. But I believe that since the curves that I showed you, the results will support the concept of the neoadjuvant treatments. The global chair is Alexander Vanakoy. I am the chair of this study for Europe. So you can contact me or Alexander if you want to get more information about. Then the last part is the role of surgery in stage 4. I think most of you may remember the important statement that 20 and more years ago Donald Morton was giving us. The concept was that the only way we had to treat patients with stage 4 was to do surgery, because with chemotherapy we only had very limited amount of results, only 5% of survival. Well, this was meaning that you were operating a lot. You were operating patients with lung metastasis, you were operating patients with liver metastasis, and so on, a situation that nowadays would be absolutely unacceptable. And this is because finally we have effective treatments. So we still may have a role for surgery in stage 4, but this has to be discussed in a multidisciplinary setting with your medical oncologist, with your radiologist, with your pathologist, all together to decide what is the best strategy to treat your patient. To conclude, primary melanoma, no discussion about. 1 centimeter margins, I think it's more than enough. Surgery for nodal metastasis has become really no more necessary in the great majority of patients, and this is through the treatment with adjuvant treatments. The role of pathologists is very important. The role of pathologists is very important, and it's becoming more and more important also in the neoadjuvant setting, because we need the pathologist, for example, to evaluate the response that the neoadjuvant treatment has given to the locoregional nodes. It's very important to say if the node has a complete regression or semi-complete regression of the disease, or there is very minimal response or no response at all, because this will really change our approach for the patient with locoregional metastasis. And the medical treatments are now able to save nearly 50% of the lives of patients with advanced disease. The point is, what happens to what we can do of the other 50% of patients? Of course, this is a big topic because it's a topic linked to the important investments that need to be done, which are much higher probably than the investments that we had to discover the role of anti-CTLA-4 and of anti-PD-1 drugs. Probably we need much higher investments from the big pharma, and we really hope that this may happen in the next future. Said this, I would really like to thank you very much again for the invitation to come here, and to the Oncoliando and to Dr. Xavier Soteldo, who invited me directly as a good friend. Thank you very much for your attention.
Grazie mille, grazie mille. Microfono 1. Hola, hola. Grazie mille, doctore. A continuación, continuaremos viajando por Italia. Nos acompañará el día de hoy el doctor Michele Maio. Nos acompañará desde Italia también el doctor Michele Maio, quien es director del Centro de Inmunología, Unidad de Oncología Médica e Inmunoterapia del Hospital Universitario de Siena. El doctor Maio nos compartirá el tema éxitos y dificultades de la inmunoterapia en tumores sólidos, una mirada al futuro. Esta ponencia contará con traducción simultánea. Bienvenido el doctor Maio. Bienvenido, doctor. traduzione, però la traduzione va a allungare el tiempo. Esatto. Si se puede reducir un poco sería perfecto, genial.
No, non posso ridurlo perché non riesco a fare un ragionamento. Ho ascoltato presentazioni di un'ora, anche nitide, se posso dirlo, quindi cercherò di essere veloce. Però quindi mi fermo per far parlare
Exacto, usted parlare, pero corto, y la traducción.
Ah, ok.
Perfetto. ¿Vamos bene?
Grazie.
Perfetto. Grazie mille, dottore.
Grazie. Okay. Buenos dias. You don't need to translate this. I also need to thank Oncoaliado for the kind invitation. I'm very happy to be here. I'm honored to be here, and I must say some of the presentations that we have had this morning were very inspiring and very, very useful. To me, at least as a medical oncologist. Before I go into my presentation, I have a warning. We have just heard the presentation from Dr. Testori. Alessandro is a surgeon. I must say that in the last 10 years, the medical treatment approach to cancer therapy has changed dramatically. I will have to stop because we have a translation. So, shall I go ahead?
Yes.
Okay. So, I will give you some examples of what has been happening in the medical treatment of cancer in the last 10 years.
Entonces, voy a darles algunos ejemplos de lo que ha sucedido en el tratamiento de cáncer en los últimos 10 años.
Okay, so those are my declaration of interest. What has been happening? What has been the major change in the treatment of cancer that we have faced?
¿Cuáles son los mayores cambios en el tratamiento del cáncer que hemos estado poniendo en práctica?
The three options that we have had for years are surgery, chemotherapy, and radiotherapy, alone or all together.
Entonces, últimamente, siempre hemos tenido estas tres opciones que son cirugía, quimioterapia o radioterapia.
But the immunotherapy that has failed for decades has dramatically changed the treatment landscape of cancer.
Pero ahora tenemos también la inmunoterapia que ha cambiado dramáticamente la posibilidad de tratamientos.
We are going good. We are going good. And how did it change? It changes because we understood how our immune system works through the so-called immune checkpoints, which are expressed at different stages of activation of the immune cells.
Y la manera que tenemos para estos cambios es que hemos estado trabajando con los puntos de control para activar o bloquear los agentes para contrarrestar las inhibiciones de los tumores.
And I will mainly focus on two of these checkpoints that are CTLA4 and the PD-1/PD-L1 axis.
Entonces vamos a enfocar estos dos puntos de control que son el CTLA4 y el PD-1.
That have been discovered, as you know, by these two guys, Jim Allison, who discovered CTLA4, and Tasuku Honjo, who worked and discovered the PD-1/PD-L1 axis, and they received the Nobel Prize in 2018.
Esto lo podemos hacer gracias al estudio del Dr. James Allison y Tasuku Honjo, que recibieron por eso el premio Nobel en el 2018.
I will try to go briefly through the different stages of the disease in which immunotherapy has changed or is changing the therapeutic landscape of cancer.
Entonces voy a tratar de voy a pasar por los varios estadios en los cuales la inmunoterapia ha cambiado o está cambiando la manera de trabajar en las clínicas.
And among those listed on this slide, I will skip, due to the time constraints, the adjuvant setting, which is also very important anyway.
Voy a pasar por encima de la parte, el estadio de adyuvante, porque ya por cuestiones de tiempo.
Some of the results that I will show you have been generated by our own group, our own research group in Siena, with the support of a non-profit foundation, that's the NIBID Foundation.
Algunos de los resultados que voy a mostrar han sido logrados gracias a la fundación en la cual trabajo en Siena, que es la NIBID.
As Dr. Testori said, the role of surgeon has been very important. I don't want to say in the past, it's still very important, but there are clinical situations in which the surgeons cannot help.
Hay algunas situaciones en las cuales los cirujanos no pueden actuar. En los casos de melanoma, que sin embargo sigue siendo un instrumento muy útil para la investigación sobre el cáncer.
And until a few years ago, for advanced or metastatic disease, we had practically no clinical therapeutic opportunities for our patients. We used chemotherapy, but we knew that chemotherapy did not impact the overall survival of metastatic melanoma patients.
Okay, hasta hace unos años, a pesar de que usáramos la quimioterapia como la manera más general de tratar el cáncer, sabíamos, sin embargo, que eso no mejoraba la supervivencia de los pacientes. Right?
Okay, so what's the situation today? This is an update of a clinical trial that has been published, that we published a few months ago, that demonstrates that metastatic melanoma patients, when they are treated with a combination of an anti-CTLA-4 and an anti-PD-1,
este estudio tiene unos meses apenas de haber salido y muestra la supervivencia de los pacientes con un tratamiento que usa estos dos fármacos, nivolumab y ipilimumab.
they show a melanoma-specific survival of 50%, over 50%.
Y lo que muestran es un porcentaje de supervivencia mayor al 50%.
And this compares with a few months of survival for these patients that we had before having available immunotherapy.
Y esto se puede comparar con apenas unos meses de supervivencia que teníamos antes de la aplicación de la inmunoterapia.
This morning we have heard about brain metastases in non-small cell lung cancer. Melanoma is one of the tumors, is among the tumors that most frequently metastasize to the brain.
El problema es que el melanoma es uno de los tumores que con frecuencia puede hacer metástasis en el cerebro.
And again, for those patients with brain metastasis, we had only surgery and radiotherapy because we had no other therapeutic strategy that could take care of brain metastasis.
Entonces, el problema con los pacientes que tienen metástasis en el cerebro es que las únicas herramientas que tenemos para trabajar con ellos son o la radioterapia o la cirugía, porque no hay ningún otro tipo de tratamiento que podamos usar.
But thanks to the immunotherapy, we started to break the dogma that the immune system could not reach brain metastasis.
Pero gracias a la inmunoterapia hemos podido romper el dogma de que no se puede atacar el cáncer de cerebro.
This is a very short list of clinical trials in which immunotherapy was tested first for the treatment of brain metastasis. And I will not go through all these studies.
Aquí tenemos una lista muy corta de distintos estudios que han tratado, donde se ha tratado el tumor de cerebro con inmunoterapia y no voy a pasar por todos los estudios.
But the studies that have changed the story of asymptomatic brain metastasis in melanoma, excluding then radiotherapy and excluding surgery, are listed in this slide.
Sin embargo, como pueden ver, estos estudios para metástasis en el cerebro han funcionado incluso sin el uso de radioterapia ni cirugía.
This is a list of 3 different clinical trials that were performed in the US, in Australia, and in Europe through the NIBIT Foundation.
Aquí pueden ver 3 publicaciones que hablan de 3 estudios que se hicieron en Estados Unidos, en Australia y en Europa.
These studies were very similar in terms of recruitment of patients. Those were patients untreated with asymptomatic brain metastasis that were enrolled in the different clinical trials.
Aquí pueden, en estos 3 casos se usaron pacientes con metástasis en el cerebro sin...
The countries? No, I don't know. With brain metastasis asymptomatic, untreated.
Sin,
No, we knew they had. We knew they had brain metastasis.
sin manifestaciones.
Okay. Now, I want to make a long story short, and what the results are for these patients who had very few months of overall survival between the advent of immunotherapy.
Pero lo que quiero destacar es que estos pacientes tratados con inmunoterapia,
The results are shown here in this slide, in which our group has first demonstrated that at 7 years, over 40% of melanoma patients with brain metastasis are alive with no evidence of disease.
aquí lo que se ha demostrado es a lo largo en este estudio de a lo largo de 7 años es que más del 40% de los pacientes han tenido una supervivencia de más de 7 años.
And this is the very first long-term update available demonstrating that immunotherapy can hopefully cure also patients with brain metastasis.
Y este es el primer estudio de largo término que está demostrando que con la inmunoterapia se puede efectivamente tratar el cáncer de cerebro con resultados positivos y sin relapso.
Sorry. Moving to lung cancer. We had the presentation this morning, so I have removed a few slides.
He tenido que eliminar algunas diapositivas de la presentación.
For non-small cell lung cancer, this is the story of medical treatment of non-small cell lung cancer. Until very recently, there were no patients who would survive over 5 years.
En este caso se puede ver en este estudio cómo el índice de supervivencia de los pacientes ha sido mayor de 5 años.
But thanks to immunotherapy, those patients now exist. So we may have non-small cell lung cancer patients with advanced disease that survive over 5 years.
Así que con la inmunoterapia se pueden tener pacientes que sobreviven más allá de 5 años gracias a este tratamiento.
And the treatment of lung cancer as we heard this morning, has become very complex. But just to give you a flavor of what combined immunotherapy can give,
Entonces, este tratamiento de cáncer de pulmón, que como saben puede ser sumamente complicado, les quiero mostrar los resultados del tratamiento combinado de inmunoterapia.
in this paper, we showed quite recently that at least 35% of patients have an overall survival when treated with the combination of a CTLA-4 and a PD-1.
I'm sorry.
The slide shows that
Yes, the first, la primera muestra el resultado de los pacientes tratados con
treated with the combination of an anti-CTLA-4 and an
la
anti-PD-1.
combinación de estos dos fármacos, nivolumab y ipilimumab.
And on this part of the slide is clearly shown that when immunotherapy works, it works for a long time. This is the survival curve of patients who achieved an objective response.
Entonces, en la segunda lámina se puede ver claramente cómo el tratamiento combinado con inmunoterapia aumenta enormemente las posibilidades de supervivencia de los pacientes.
Okay. Another important achievement has been in pleural mesotelioma.
Otro logro muy importante ha sido con el mesotelioma pleural.
As you know, pleural mesotelioma is a disease for which we had practically no treatment.
Es una enfermedad, el mesotelioma pleural, para la cual prácticamente no hay ningún tratamiento o no teníamos ningún tratamiento.
But in the last 10 years, a number of clinical trials, which I must say have been developed in our group by Dr. Luana Calabro, who treated mesothelioma patients first line or second line with anti-CTLA-4 and then in other studies with the combination anti-CTLA-4 and PD-1.
En cambio, tenemos en los últimos 10 años a unos doctores que se pueden ver en estos estudios que trataron a estos pacientes de fase 1 o fase 2 con esa combinación de fármacos con resultados positivos.
These 4 clinical trials that Luana has published paved the way to registrational trials, phase 3 trials in mesothelioma.
Estos 4 estudios que se pueden ver aquí han prácticamente sentado el terreno para poder continuar con los estudios y son un punto, turning point, una manera de cambiar completamente la visión sobre esta enfermedad.
And these are the results that have been published a couple of years ago, 3 years ago actually, demonstrating that immunotherapy with anti-CTLA-4 and anti-PD-1
estos 3 estudios que están aquí, que son los últimos, demuestran que usando la inmunoterapia con estos fármacos podemos tener unos resultados
can benefit mesothelioma patients regardless, in this part of the slide, of the histology of the tumor.
Aquí se ve el resultado sobre el mesoteloma sin importar el tipo de, I'm sorry, kind of, regardless of,
The histology of the tumor.
sin importar la histología.
Indeed, when these patients were divided into the epithelioid and non-epithelioid histotype,
Se dividieron los pacientes en el grupo de epitelioides y no epitelioides.
there was still an advantage for patients with epithelioid mesothelioma,
Y de todas maneras, incluso sí había una ventaja para los pacientes con epitelioma,
but the highest advantage was for patients who had the sarcomatoid mesothelioma or a biphasic mesothelioma.
Y sin embargo, todavía era mayor la ventaja para los pacientes con mesoteloma, perdón.
So this study has led to the approval of the combination ipilimumab and nivolumab for the treatment of phase of advanced first-line pleural mesothelioma patients.
Así que estos estudios demuestran las bondades del uso de la inmunoterapia con estos fármacos para el tratamiento de los pacientes con mesotelioma.
But the number of patients, as I said before, also in the epithelioid mesothelioma benefit from treatment. And in Italy, for example, those patients cannot receive the combination ipilimumab and nivolumab because it's not registered and reimbursed.
En Italia, algunos de estos pacientes no pueden recibir el tratamiento de ambos fármacos combinados porque hay unos de esos que están todavía, que no han recibido la aprobación, pero de todas maneras, incluso si no se combinan los fármacos, se ve que tienen resultados positivos.
So that means we need biomarkers that can allow us to identify who are the mesothelioma patients, regardless of the tumor histotype, that can benefit from immunotherapy.
Con esto entonces se demuestra que los pacientes que tienen cáncer, sin importar cuál tipo de cáncer, pueden beneficiarse con el uso de la inmunoterapia.
So what we did, we set up a consortium that is supported by the Italian Association for Cancer Research.
Lo que hicimos fue que hicimos un consorcio de 7 grupos de trabajo bajo el consorcio del estudio de cáncer en Italia.
And among other studies, we focused on mesothelioma.
Y entre distintos cánceres tuvimos un foco especial en el mesotelioma.
And the results, which are still unpublished, clearly demonstrated that regardless of the mesothelioma histotype,
y los resultados muestran con toda claridad que sin importar el tipo del mesotelioma,
patients could be divided into 4 methylation classes for their DNA.
Se pueden dividir a los pacientes en 4 tipos según la medicación que más les conviene.
And what came out by classifying patients for the extent of methylation of their DNA,
y al clasificar los pacientes según la metilación de su ADN,
there is a strong correlation, as you can see here, between the methylation classes and survival.
se puede ver claramente una correlación entre la clase de metilación de los pacientes y su índice de supervivencia.
This data demonstrate clearly that patients with an hypermethylated DNA
O sea
do
que es
worse in the course of immunotherapy.
higher survival.
Yeah.
Eso demuestra entonces que los pacientes que tienen una alta metilación de su ADN tienen también una mayor capacidad de supervivencia contra el cáncer.
So we probably have a biomarker that, regardless of the histology of pleural mesothelioma, can help us to identify those patients who will respond better and survive longer with immunotherapy.
Esto entonces nos indica que si podemos identificar cuál es la clase de metilación de los pacientes, eso nos va a ayudar a escoger cuál es la medicación más adecuada para ellos para que tengan un índice de supervivencia mayor.
Okay, so unfortunately, I have to stop here due to time restraints, also for the translation. but the slides are available in case anybody wants to utilize them. And again, and once more, I thank Oncoaliado for the very kind invitation to this very nice meeting. Thank you.
Desafortunadamente voy a tener que parar aquí por cuestiones de tiempo, pero les invito a revisar los resultados que amplían esta información y la importancia del uso de la inmunoterapia para aumentar la supervivencia de los pacientes con cáncer.
Thank you.